Good evening, everyone.
Good evening.
I have the pleasure of moderating today's session. We are honored to be joined by our distinguished chairperson, Dr. Mohammed Shamsuddin, and our speaker, Dr. Afifa Afsar, who will be discussing the early management of spinal cord injury in line with WFNS Spine Committee recommendation. This topic of critical importance, where timely decisions can profoundly impact outcomes. Dr. Afifa Afsar, the platform is yours.
All right. Good evening, everyone, and good to have you all. And thank you for the honor for inviting me as a speaker for this particular topic. So, without further ado, we would start. And so, the topic of our tonight's lecture is basically early management of spinal cord injury, as Dr. Mohammed told us, in line with WFNS Spine Committee recommendations. So when we talk about the epidemiology of spinal cord injury, we know that almost 50,000 spinal injuries occur annually, and half of them are located in the cervical spine. Almost 11,000 of them are going to result in spinal cord injury. The factors that usually lead to a delayed diagnosis in these patients are some significant core players. So there is usually concurrent head injury because these are patients usually affected by high energy traumas. So there is altered state of consciousness. That is why there is lack of assessment. There's poor radiographic visualization, and there is multiple other, that is, these are usually polytraumatic patients. So there are multiple other injuries that lead to a delay in the diagnosis pertinent to the spinal cord. So the initial management is very crucial in these patients. So what is important is a very thorough evaluation as per the ATLS protocols, as we all are aware of. Good resuscitation, immobilization, as well as extrication and transport of these patients to level 1 neurotrauma care centers, where they can be assessed properly and then can be provided subsequent care as needed. So coming to the basics, neurologically, spinal cord injury is classified into two, that is complete and incomplete cord injury. Complete cord injury means that there is no motor or sensory function caudal to the level of the injury. However, incomplete cord injury is defined by some degree of motor or sensory function below the affected area that is preserved. And this is why the injury is called as incomplete cord injury. So further, incomplete cord injury is basically divided into four basic syndromes. That is central cord syndrome, anterior and posterior cord syndromes, and Brown-Sequard syndrome, which is also called as hemicord syndrome. Excuse me. When we talk about incomplete cord syndromes, so this is a brief overview. This is a cut section of the spinal cord. We can appreciate that these are the dorsal columns, which are responsible for the vibration and proprioception. Then on the lateral aspect, we have spinothalamic tracts, which are responsible for the sensation of pain and temperature. And the anterolaterally, we have the corticospinal tracts, which are basically responsible for the motor pathways. So anybody who is suffering from an anterior cord syndrome, basically, this is the yellow area that is affected, as going to be suffering from bilateral loss of motor, pain, and temperature sensation below the level of injury. However, he's going to have intact vibration and proprioception. Usually, this is associated with hyperflexion injuries or disruption of anterior spinal cord artery. Anterior spinal artery, which usually supplies the major chunk or 2/3 of the spinal cord surface. Then we talk about the central cord syndrome. Central cord syndrome is usually going to result in sensory and motor deficits alike, but the upper extremities tend to be affected more than the lower extremities, reason being that the upper extremities are more medial on the surface mapping. And this is usually going to result because of hyperextension injuries. And this is classically seen in elderly patients who have underlying cervical spine disease already. Then when we talk about Brown-Sequard syndrome, which is hemicord syndrome, that is going to result in ipsilateral loss of motor, vibration, and proprioception. However, there's going to be contralateral loss of pain and temperature, reason being that these pathways decussate. So this is usually seen in patients with penetrating trauma or lateral compression. So this was a brief overview of the incomplete spinal cord syndromes. Now we're going to talk about in the forthcoming slides about the medical management and the role of surgery in patients with spinal cord injury and what is the basic evidence that we have till date. So the Brecken et al. In 1990 gave this concept in the National Acute Spinal Cord Injury Study that the optimal therapeutic window for the patients with spinal cord injury is up to 8 hours. And so we got this concept that early intervention is required in these patients, and as early as within a span of 8 hours. So this concept was given to us back in 1990. However, the study was basically based on pharmacological therapy and the role of methylprednisolone in the patients with spinal cord injury for the initial 24 to 48 hours. But the significance of putting the slide up here and basically pretending that there is a significant role of managing these patients as early as possible, and as early as possible meaning that up to an 8-hour window. Then there was a second study which was done by Lee and his colleagues, which was based on the fact that minimizing secondary injury is the only therapeutic option to influence the neurological outcome in these patients. So thus he conducted a study comparing early surgical decompression, that is early means within a span of 24 hours, and very early, that is like ultra surgical decompression happening within 8 hours. So their results showed that there was a significant better neurological outcome if the patient was operated in the initial 8 hours as compared to the patients who were operated between a window of 8 to 24 hours. However, because this is a level 3 evidence, because it was a single center study, so they did fail to demonstrate that what were the better secondary outcomes related to the timings of the surgery. But yet again, this was proposed that ultra early surgery, that is a decompression that is done within the span of 8 hours, is going to have good neurological outcome as compared to a patient who was operated beyond the 8-hour window. Then Grasner further discussed this, and he also examined the decompression within 8 hours and the clinical outcomes of those patients at a 1-year follow-up. So they utilized the AIS, which is the American Spinal Impairment Scale, American Association Spinal Injury Impairment Scale, and the SCMI. And in detail, they found that there were significant differences in the AIS grade after 1 year between the patients who were operated early, between their neurological and motor levels as well, because they were both found to be caudal in cases of early decompression. However, it was also seen that there was no significant difference between the first assessment that was done after surgery and an assessment that was done at a 1-year follow-up. So there was significant increase in the AIS grade in 1 year after injury between both the groups, and significantly higher AIS conversion was seen in patients who were decompressed within the first 8 hours, further endorsing the fact that early decompression is necessary for patients who are affected with spinal cord injury. So then there was another study that was conducted in 2015, which was a meta-analysis that whether urgent decompression was superior to delayed surgery for traumatic spinal cord injury. So Liu did the same, that he utilized the surgical timing, demonstrated that if you were basically going for patients for early decompression, so these patients demonstrated shorter hospital stay, and there were fewer preoperative, perioperative complications were noted in patients who were operated within a 24-hour window, as compared to patients who were opted for surgical decompression after a 24-hour window. So there's significant improvement and difference in the total motor score as well, and their neurological improvement rates, as well as their length of hospital stays. There was further a meta-analysis that discussed the early surgical decompression is going to improve the neurological outcome after complete traumatic subcervical spinal cord injury. So TER, and this was basically their targeted population was primarily complete cervical cord injury patients, that complete cervical spinal cord injury patients, because usually these patients, they tend to get ignored because of the fact that there is no neurology below the level of injury. So the purpose of analyzing the outcomes in this specific population was that they wanted to know whether this does create any kind of difference. So they did perform a meta-analysis, and they provided a class 2 level of evidence that early surgical decompression, especially in patients with complete spinal cord injury, they consented better outcomes of at least 2 Asia grades, in contrast to the patients who had incomplete spinal cord injury, which were their benefits. And it was not like that their results were not better. The incomplete spinal cord injury, we all know that the results are better with early surgical decompression. But what they're trying to prove is that in patients specifically with complete spinal cord injury who were urgently decompressed, that is within the span of 24 hours, they showed a better outcome of at least 2 Asia grades. So if anybody goes from an Asia A to Asia C, that's still better for the patient. The basic dilemma that we encounter in these patients for surgery are two major factors. And the majority of the studies, they basically cited that there's two reasons for the delay. The two reasons for the delay were basically the time that is required necessary for the transportation, especially to a level 1 trauma care center, which is going to provide them appropriate care. And the second one is the necessity to stabilize these patients before surgery because they're usually polytraumatic patients, so they're associated injuries as well. So they were in consequent studies and multiple studies, it was shown that there were two major factors that proposed a hindrance to the early surgical management of spinal cord injury. That was their primary transportation to a level 1 neurotrauma center, and secondly, their necessity to be stabilized enough so that they can undergo a spinal surgery. Now, that was about the surgical decompression and the need for urgent surgical decompression in this particular patient population. Now, coming to the medical aspect of the spinal cord injury. So there are a lot of myths about the medical management. So we're going to be busting some few myths about it, and let's see how we go. So in the clinical series of humans, it was noted that patients with acute spinal cord injury that were managed in an aggressive fashion with primary attention to their blood pressures, their oxygenation levels, their hemodynamic performances, they showed no deleterious effects of therapy, and they suggested improved neurological outcomes, suggesting that yes, in these patients, it's very important to give complete importance and complete preference to the hemodynamic stability, to maintain their blood pressures adequately. Maintaining their MAP is very important. Why? Because we are supposed to maintain the spinal cord perfusion pressure. And if spinal cord perfusion pressure is maintained, that is going to result in good outcomes. Despite these observations, multiple patients still with acute spinal cord injuries treated in contemporary practice are not routinely monitored in an ICU setting or treated with aggressive blood pressure augmentation after injury. The impact of blood pressure management after spinal cord injury, a systematic review of literature. Again, there were multiple studies that were done going all the way from 91 till 2016, which suggested that evidence says that hypotension with neurological injury results in poorer outcomes. However, there's significant evidence that increasing blood pressure is going to promote better outcomes in these patients, improving their ASIA grades as well when we go for the urgent decompression in these patients. So, aggressive cardiopulmonary resuscitation, like we are enforcing on. So incomplete spinal cord injury, it was noted that there's clinical improvement for 92% of these patients after 12 months, and there was improvement in approximately 42% of the patients who suffered complete spinal cord injuries if they were managed with aggressive cardiopulmonary resuscitation. So these efforts are going to result in improved neurological outcomes in patients with acute spinal cord injury. Now, we had some animal experiments related study as well, further endorsing the point of view of how important it is to maintain the spinal cord perfusion pressure. So the lab evidence suggests that hypotension is going to contribute to secondary injury after acute spinal cord injury by further reducing the spinal cord blood flow and perfusion, and hypotension in animal models of spinal cord injury resulted in worsened neurological outcome. Then, according to the 2013 WFNS guidelines as well, we had level 3 recommendations, and there were multiple studies that were done by our colleagues Zach, Levy, and Headley, which recommended that correction of hypotension and spinal cord injury, that is a systolic blood pressure of less than 90, needs to be corrected when possible and as soon as possible is recommended. And maintenance of a MAP between 85 to 90 millimeters of mercury for the first 7 days following an acute spinal cord injury is recommended in order to have good outcomes in these patients. Then the differential effects of certain drugs like norepinephrine and dopamine on the CSF fluid pressure and spinal cord perfusion pressure after acute injury. So it was noted that norepinephrine was able to maintain a MAP with a lower intrathecal pressure and a correspondingly higher spinal cord perfusion pressure as compared to dopamine. And that is why it was suggested, and it is still suggested, that norepinephrine is going to be preferable, and it is preferable to dopamine as an inotropic agent in patients for spinal cord injury. So again, Wormser and his colleagues, they did a study, and they proposed that systemic hypertension is going to frequently occur after hemorrhage and neurogenic shock in these patients, and this shock is usually going to result from the loss of supraspinal sympathetic control and vasodilation, and subsequently result in hypotension and inadequate tissue perfusion, leading to decreased perfusion pressure in the spinal cord tissue as well. So the three drugs that we have are dopamine, norepinephrine, and epinephrine. These are all alpha and beta 1 agonists, and they have good properties and they're acceptable options. But phenylephrine is going to work as another drug, that is phenylephrine, which is going to work as an alpha 1 receptor agonist. So this is going to have minimal beta 1 effects, which is going to be peripheral. So this may have an effect that it can lead to reflex bradycardia. So basically, this is not recommended. The usage of butamine for treating spinal cord injury is again limited because like we said, that norepinephrine is the preferred drug of choice as compared to dopamine or dobutamine because of its effect on the vasodilation and again the possible risk of reflex bradycardia. So we don't want these patients to go into bradycardia as well. We want to maintain these pressures with a good map and a good heart rate as well. So we have to selectively then select an inotropic agent that is going to be maintaining both. So for that, it is time and again proven that norepinephrine has good results. Then another study that was conducted by consortium for spinal cord medicine. So they also proposed in 2008 that the level of spinal cord injury and patient's hemodynamics, so it is going to depend on that. So in cervical or higher thoracic lesions, which are going to have both aspect of hypotension as well as bradycardia. So we need to have a drug that is going to have good vasoconstrictive properties and is not going to be causing reflex bradycardia as well in the patient. So that is why norepinephrine is considered as a good option in these patients as well. However, in patients with lower thoracic lesions, we know the hypertension is usually happening because of peripheral vasodilation. So pure vasopressor drug like phenylephrine could be appropriate as well because in patients with lower thoracic lesions, we know that they don't have the problem with the reflex bradycardia. So when we talk about complications, there was another study that was conducted and it said that complications and outcomes of vasopressor usage in acute traumatic spinal cord injury syndrome. So there were like approximately non-significant higher complication rates were noted with dopamine, approximately 68% of the patients who received it. So that was like around 21 out of 31 and 45% of the patients were treated with phenylephrine. So it is usually said that patients who have an age group of above 55, dopamine may produce statistically significant increases in complications, which were not observed with phenylephrine. So if we have to select a drug between dopamine and phenylephrine in an age group that is elderly, that is above 55, then phenylephrine again is considered as a better option. Then predictors, when you talk about predictors for poor cardiovascular and respiratory functioning in these patients, so those are like higher cervical injury, as high it is. So we know that the risk of respiratory complications is going to be high, and obviously cardiovascular compromise as well because of sympathetic pathway disruption. Then there's complete spinal cord injury. So we know there's lack of diaphragmatic function. There is advanced age and previous comorbs or like previous cardiopulmonary disease, tachypnea at the time of admission, copious sputum and secretions, pneumonia, and major lung lobe collapse. So these are all predictors for poor cardiovascular and respiratory functioning in patients with spinal cord injury. Then coming to respiratory complications, because these are like one of the most common complications that we encounter, and they can be like threatening and dreadful as well. So approximately 2/3 of these patients will have complications like atelectasis, pneumonia, or respiratory failure that would require mechanical ventilation. And the injury level and the age classification are again the two most important predictors for the need for intubation. Virtually 100% of these lesions above C5 level are going to require intubation, reason being that the phrenic is going to usually originates from C3 to C5. So if anybody is going to have a lesion above it, is going to have a diaphragmatic compromise. So this should be done electively in these patients rather than opting it as an emergency. Then what is recommended is that we avoid hyperextension in these patients, rotation and other movements of the neck when they're not stabilized. When possible, awake fiber optic intubation should be done with inline stabilization without traction is usually an alternative when a fiber optic laryngoscope or bronchoscope is unavailable. For further talking about respiratory complications, only 40% of these patients who are having a lesion above C4 are successfully extubated. So the predictors for the need for tracheostomy are Asia A patients, history, and smoking. Early tracheostomy taking place within the span of 10 days in these patients is going to lead them to a shorter ICU stay and reduction in their length of time of mechanical ventilation, because The more prolonged the patient is on ventilator, they tend to become ventilator dependent. So early track is why recommended in these patients who we know that are going to have some degree of diaphragmatic compromise. So as soon as before their own respiratory efforts start to die out, so it's better that they go into that aggressive phase of physiotherapy and respiratory physiotherapy basically. So and we bypass that area of the airway. Then most early deaths usually take place in these patients due to pulmonary complications, and this was again supported by systematic review of intensive cardiopulmonary management after spinal cord injury. And respiratory insufficiency was seen in 70% of the cervical complete injury patients, as compared to 27% in incomplete injury patients. Respiratory complications were higher and highest in patients having lesions within the region of C1 to C4, approximately 84%, and 80% of them required ventilation. So it is important that level of the cervical injury, completeness of the cord injury, the age, the previous diseases or comorbs and tachypnea at the time of admission, they are all associated with a higher likelihood of respiratory complications in these patients. So we need to be well aware what we are getting into, and we need to have an aggressive management approach towards these patients in order to avoid it. Coming to the pharmacological and regenerative cell therapy for spinal cord injury. So this is a brief overview. We'll be talking about all these drugs one by one. So we have NASA's 1, 2, 3 trial, which talks about role of methylprednisolone on spinal cord injury, then Rho inhibitors like Zetrin, then minocycline, which is an antibiotic, and riluzole, and granulocyte colony stimulating factors. So coming to methylpred, NASA's 3 was a multi-center prospective study, which was a double-blinded trial, and a randomized trial included approximately 500 patients. So these patients were treated with different dosage of methylpred for different spans, like for 24 hours, 48 hours, and then like for every 6 hours for 48 hours. They were again examined at 6 weeks, 6 months, and 1 year, but they did not show any significant difference in the motor score between the treatment groups at any point in time. So there is level 1 evidence that administration of methylprednisolone for the treatment of acute spinal cord injury is not recommended. There is no class 1 or class 2 medical evidence supporting the clinical benefit of methylpred. So we all should be aware that there is level 1 evidence that has proven that methylpred has no role in acute traumatic spinal cord injury. Coming to minocycline, which is a tetracycline group of antibiotic, that has neuroprotective and anti-inflammatory properties. So that is why a single center placebo trial was conducted with 27 patients. And patients treated with minocycline, they showed motor recovery approximately 6 points greater than that in the control group in cervical cord injury patients. So that is why it has, again, level 2 evidence. Then Rho inhibitors like Zetrin, this is a recombinant inhibitor of Rho that is mainly involved in the control of cytoskeleton. So this promotes axonal outgrowth on inhibitory substrates. And the largest change in motor score was again observed in patients who had cervical injury. And approximately 6% of these patients with acute thoracic cord injury, they converted from Asia A to Asia C or D, as compared to patients with 31 patients with acute cervical cord injury. Then we talk about riluzole. Riluzole is a benzothiazole group that inhibits voltage-gated sodium channels and promotes glutamate release. So Grossman conducted this prospective multi-center trial and for the safety and pharmacokinetics and preliminary trial for riluzole. So this was a study that was conducted again on 36 patients, and they were categorized usually in the Asia A to Asia C group, basically. And this was administered twice a day with a difference of 12 hours in these patients. So control group was there, and they were matched for the neurological outcome and impairment and sex and age and everything. So patients with impairments, Asia impairment scale B, they showed the highest improvement who went treated with riluzole according to this study. Then we talk about granulocyte colony stimulating factors. This is again a growth factor for the activation and differentiation of granulocyte colonies in the bone marrow. And it was noted there's a significant improvement in Asia motor score was detected with these groups 1 week after the administration compared with the control group. And this was again, CAMIA conducted the study in 2014, and there was a clinical trial that did confirm the safety and feasibility of this as a neuroprotective pharmacological therapy in patients with spinal cord injury. this is considered as a neuroprotective agent, and clinical outcomes showed in that patients who were treated with granulocyte colony stimulating factor, and they compared the results with the historical cohort of spinal cord injury patients having been given higher doses of methylpred. This suggested that the granulocyte colony stimulating factor is basically more safe and superior to methylpred in terms of the clinical outcomes of acute spinal cord injury. So this is all level, then we come to level 3 evidence study. So there are other chemical substances as well that help prevent further progression of spinal cord injury, and in some instances it does improve those injuries as well. But these are all level 3 evidence, and the reliability, however, is obviously going to be lower as compared to level 1 studies or level 2. So we have paclitaxel, which is an oncology therapeutic agent. We have inosine, we have testosterone derivative of fibroblast growth factor, aminopyridine, baclofen, lycium barbarum, riluzole, molybdenum disulfide. So these are certain chemicals that have some role, but then again, the patient level, the level of evidence is just level of evidence is grade 3. So we can't just be going on with these drugs. Then we talk about mesenchymal stem cell transplant for these patients. So currently there is a row about marrow-derived mesenchymal stem cell transplant, and we have two. So we have umbilical cord-derived mesenchymal stem cell transplant, and we have adipose tissue-derived mesenchymal stem cell transplant. So they have been tried for the treatment of a spinal cord acute injury. And there's again lack of phase 3 trial that is exploring the therapeutic efficacy of this transplantation. It's caused by several reasons, again, including the regulatory issues that are concerning the therapeutic applications, the higher cost again, and low patient willingness to receive novel therapies without concrete level of evidence. So there was a study that was conducted by in 2016, and that examined the effectiveness of this therapy. So 16 patients for chronic spinal cord injury were treated with, and they got their stem cells were taken basically from their adipose tissue, and it was injected into the intramedullary and subdural space, which resulted in pure therapeutic effect, whereby only 2 patients of them, they showed neurological improvement. So this, again, suggesting that this could be a line of treatment for patients with spinal cord injury. So this is stem cell clinical trials that have been going on in the States and elsewhere, which suggests that yes, there is the role of stem cell transplantation in patients with spinal cord injury. So again, like concluding it all, pharmacological treatment as an adjunct to spinal cord injury has again always been a topic of debate, and the role has been proven controversial in treatment of spinal cord injury. So class 3 studies are required, need randomized trials, for its clinical application in spinal cord injury. So we have a lot of level 3 evidences proving that this therapy or this newer agent is going to be helpful, but we require good RCTs in order to support the complete scientific evidence that these are they have good clinical application in spinal cord injury patients. So now I would be, because we're done with the medical management and we're done with the surgical aspect of decompression required in spinal cord injury patients. So now I'll be summing it up with the final recommendations of World Federation of Neurological Society for the spinal cord injury patients. So emergency care and early management, the first recommendation is early surgery within a span of 8 hours should be performed in most cases of spinal cord injury. Corticosteroids are not indicated in majority of the acute phases. If feasible, spinal cord injury patients need to be treated in a specialized level 1 neurotrauma center. The recommendations regarding the cardiopulmonary resuscitation of these patients: mean arterial pressure above 85, as we discussed earlier, for 7 days in patients with acute injury is going to improve the neurological outcome. Correction of hypotension in spinal cord injury is required when possible and as soon as possible. Patients with spinal cord injury suffer from cardiac issues, including hypertension and bradycardia, and it's going to be worse in complete injury. So we need to be very careful with aggressive vasopressors. In cervical or high thoracic lesions having both hypotension and bradycardia, a drug like norepinephrine, having both chronotropic as well as inotropic effects, is going to be serving as a good vasoconstrictor. Level of the injury, completeness of the injury, the age, previous disease, and tachypnea at the time of admission are all associated with a higher likelihood of respiratory complications in these patients. Hence, these patients should be aggressively nursed. Recommendations for the pharmacological therapy for acute spinal cord injury. There is not good evidence that high doses of methylpred administered for acute spinal cord injury is beneficial in correlation with its higher rate of complications. In selected young patients with acute spinal cord injury, 24 hours infusions of high doses of methylpred administered within 8 hours of injury can be suggested. Against acute spinal cord injuries, there is no pharmacological agent with high level evidence that actually can be administered as a therapeutic agent till date. So that was it. This is the link for anybody who wants to go onto the site and can have direct access to the WFNS Spine Committee recommendations. And that's it for tonight from my side. Thank you.
Thank you, Dr. Afifa, for that clear and insightful presentation. We'll now move on, into the discussion and question and answer segment. If anyone have a question for Dr. Afifa.
Yes,
May
please.
I ask a question, Dr. Afifa? In acute spinal cord injury, we all know that treatment usually starts before arriving to hospital, like transportation and how immobilization of the spine. And also, you didn't mention the rule of closed reduction of the cervical spine injuries. If you can say a little comment about that.
All right. Because considering the topic was WFNS Spine Committee recommendations, obviously acute management for spinal cord injury spans a vast horizon. And like I mentioned, obviously transportation is one of the most important aspects in these patients. So we're going to be, again, if you are at a trauma site and the patient is, we're suspecting a higher cervical cord injury or complete cervical cord injury, unless proven otherwise. So we know that we need to have inline stabilization of the neck with a Philadelphia, which is required. And again, these patients need to be transported in a good, proper spinal board, which is important. And if they are at a site, so their extrication is important, keeping in line the cervical spine. So those are the important aspects that are required. And then again, what is important is that they need to be transported as soon as possible to a level 1 neurotrauma care center. And obviously, once they reach the trauma care center, naturally, they're going to have aggressive resuscitation with regards to all their vitals as possible as per the ATLS protocol. So airway is important in these patients. Alongside with that, we take care of the cervical spine. And then once the patient's stable, then keeping in line their cardiopulmonary resuscitation, like I told you, because obviously these patients are going to have polytraumatic injuries. So we need to have a good overview that what are the associated injuries that the patient is harboring, like just not treating the spine itself, because it's a whole patient that we treat. We don't just treat one aspect of the patient. So it's a multi-disciplinary treatment that is required. But being neurosurgeons, obviously, we're talking about spinal cord injuries. So that is why I focus primarily on the medical and the surgical need of decompressions in these patients. Yeah. I hope that clears.
Thank you. And what about the rule of closed reduction of in cases of cervical spine dislocation and injuries?
Depending upon the level of the injury, like I said, and once you have the imaging, then we can go for a close reduction. But again, close reduction is recommended in settings, in control settings, obviously. So if a patient who is Asia C, then we need to see that what is the level of cervical spine injury, and then we have a role of close reduction. But then again, close reduction followed by theater open reduction is much more important than on-site close reductions. So obviously anything within the theater premises and within a controlled setting is going to have a significant role and is going to be much safer for the patient than going for close reductions on site.
Thank you very much.
Thank you.
Anyone of the attendees want to ask any question for Dr. Afifa? I'm checking the chat and it seems there are no questions. Thank you, Dr. Afifa, for an excellent and insightful presentation. And thanks to our chairperson, Dr. Shamsuddin, for guiding the session. Thanks, Dr. Ahmed Jiradi, for giving all of us this chance to share like science and knowledge. Also, thank you to everyone who joined and contributed to the discussion. Sessions like this remind us that in neurosurgery, timely knowledge translates directly into better patient outcomes. We look forward to seeing you in upcoming webinars, and have a wonderful evening.
Thank you so much.
Thank you.
Thank you.
Thank you, everyone. And as if there is no questions, we can conclude today's session. And we can see you all in next Friday with more webinars. And special thanks to Dr. Afifa Afsar for this nice presentation. And she also had contributed with more webinars before, so we thank her for that. And also thanks to Dr. Muhammad Shamsuddin, chairperson of the session, and for my dear friend, Dr. Muhammad Al-Zahir, for participating today. So thank you all and see you next week, inshallah. Thank you, Dr. Muhammad.
Thank you. Thank you.